All right, welcome to this explainer, everyone. Today we're stepping right into the clinic to set the tone for what is essentially a high-yield masterclass on age-related macular degeneration, or AMD. As a clinician, you really don't just want short-term memorization just to scrape by and pass a test, right? You want long-term clinical mastery. You want to understand the underlying biology so deeply that the imaging and the treatments just intuitively make sense. So think of this as your clinical detective's training. We're going to build your knowledge completely from the ground up. We'll start with normal cellular anatomy, progress into structural dysfunction, and ultimately culminate in absolute board-level mastery of the pathology. Let's get into it.
Here is our roadmap for today. We're going to hit ARMD fundamentals, outer retina anatomy, decoding drusen, exudative ARMD, the differential diagnosis, and then wrap it all up with a high-yield OCAP review.
Okay, starting off with Section 1, AMD Fundamentals and Epidemiology. We really need to lay the absolute foundational truths of this disease before we even glance at a single scan.
So let's lay down the mental scaffolding here. Why do we even care so much about AMRD? Well, because it is literally the #1 cause of blindness in adults 50 and older in resource-rich nations. That is a massive patient population sitting right there in your waiting room. Now, major OCAP pearl right here. What is the strongest risk factor? It's right in the name. It's age. To put that into perspective, by the time Americans hit 75 years old, a whopping 25% of them have some degree of this disease. Clinically, when you look into the macula, the absolute hallmark finding you're looking for is drusen. We categorize this whole disease state into two types: exudative, which you probably know as wet, and non-exudative, or dry. And here is a classic board question you absolutely cannot miss. What is the strongest modifiable risk factor? It's smoking. Period. When you're taking a patient history, this is the very first thing you need to counsel them on, right alongside teaching them how to use an Amsler grid so they can detect early metamorphopsia at home.
All right, moving right along to Section 2. We've covered the epidemiology, now we've got to understand the where. Let's master the anatomy of the outer retina.
To truly understand AMD, you have to understand the barrier separating the retina from the choroid down below it, and that is Bruch's membrane. But Bruch's is not just one simple single line. It's actually a multi-layered sandwich. You need to commit these 5 layers to memory, going from innermost to outermost. Number 1, the basement membrane of the retinal pigment epithelium, the RPE. Number 2, the inner collagenous layer. Number 3, the elastic layer right in the middle. Number 4, the outer collagenous layer. And number 5, the basement membrane of the choriocapillaris. A great quick mental model to remember this exact order is to think of it like a double-decker sandwich. You've got 2 basement membranes acting as your outer bread, 2 collagenous layers as the meat, and 1 elastic layer right smack in the middle. Knowing this sequence is absolutely crucial because, as we're going to see, different types of pathology live in the distinct addresses of these specific layers.
Look at this cross-section with me. Up at the top, you have your rods and cones, your photoreceptors. Notice how their outer segments physically interdigitate directly with the apical surface of the RPE cells, those yellow cells right there in the middle. Now, the RPE is resting directly on Bruch's membrane, which is that thin boundary layer we just deconstructed. And right below Bruch's, that rich, red vascular bed is the choroid, specifically the choriocapillaris. So Bruch's membrane is essentially the floor that the RPE stands on, and it's simultaneously the ceiling keeping those choroidal blood vessels from invading up into the retina. I want you to keep this exact spatial relationship locked in your mind.
So now that we have a solid grip on normal, healthy anatomy, let's introduce the clinical hallmark of ARMD in Section 3, decoding drusen on imaging. So what actually are drusen? They aren't just, random yellow spots on a fundus photo. They are the literal metabolic garbage of your eyes. Your photoreceptors are incredibly metabolically active. As they process light in the visual cycle, they're constantly shedding waste products, mainly proteins and lipids. Normally, your RPE clears all this out, but in ARMD, this clearance mechanism fails, and that waste just accumulates focally in the outer retina. This is critical to understand. Drusen physically alter the structural integrity of the outer retina, which damages the photoreceptors and ultimately leads to vision loss.
As a clinician, you must know how to grade these. On the left here, we have hard drusen. Look at how discrete and perfectly well demarcated those boundaries are. They literally look like tiny, sharp little pebbles scattered around. Now, on the right, contrast that directly with soft drusen. Notice how the borders here are amorphous, cloudy, and really poorly demarcated. Soft drusen represent a significantly higher risk for disease progression. They can even grow together into what we call confluent drusen, which completely muddies the boundaries.
Okay, let's pause for a second for some active recall. I want you to think back to that 5-layer sandwich of Bruch's membrane we covered just a few minutes ago. Where exactly do basal linear drusen accumulate? Take a mental guess right now.
Okay, here is the answer, and please pay close attention because this is a classic high-yield board trap. Basal laminar drusen accumulate between the RPE cells and their own basement membrane. They are basically sitting right under the RPE cell body. But basal linear drusen, which is what we just asked about, accumulate deeper. They are located within the inner aspect of Bruch's membrane itself. Do not confuse these two on test day. Just remember this trick. Linear goes deeper into the lines of Bruch's membrane.
Let's move on to section 4 and see how all this builds together. We are shifting from the non-exudative structural changes, the drusen, to the really devastating exudative pathology.
Before we look at the pathology itself, we have to understand the retinal blood supply. This micrograph shows a completely normal human retina. Do you see that yellow line? That line marks a hard anatomical border. Everything above that line is vascularized by branches of the central retinal artery. But look closely below the line at the outer retina, the photoreceptors and the RPE. There are absolutely no retinal blood vessels down there. The outer retina is normally completely avascular. So how on earth do those highly active cells survive? Well, they rely solely on oxygen and nutrients diffusing up from the choroid below. And the cool thing is we can actually prove this avascularity in living patients using OCTA, optical coherence tomography angiography. Look at panel C, the one labeled outer retina. It is pitch black. I want you to act as the attending pointing this out to a resident. There is a complete, totally normal absence of vascular structures in this specific zone. The outer retina should always be a vascular no man's land.
So the crucial point we're getting to is this. What happens when things go wrong? When a patient actually transitions to exudative or wet AMRD, a fibrovascular frond grows into a space where it absolutely shouldn't be. Because of the structural defects in Bruch's membrane caused by all that drusen accumulation we just talked about, abnormal vessels from the choroid break through. We call this a choroidal neovascular membrane, or a CNVM. The barrier has been breached.
Now contrast this directly with the normal pitch black OCT we just looked at. Boom! Look at that third panel. Right in the middle of the normally avascular outer retina, there is a bright, sprawling vascular front. That right there is the CNVM that has broken through. These abnormal vessels are incredibly fragile, they are highly prone to bleeding and leaking fluid, and when they do leak or bleed, the photoreceptors get disrupted, and the patient will frequently present to your clinic complaining of an acute central scotoma or metamorphopsia, basically a gray distorted spot right in the dead center of their vision. If left untreated, a subfoveal CNVM results in devastating, totally irreversible vision loss.
Now, a master clinician doesn't just memorize one disease in a vacuum, right? They build a framework. So in section 5, let's build out the differential diagnosis for exudative lesions.
If you see a CNVM, macular degeneration is obviously your primary suspect in an older adult, but the differential for exudative ARMD is actually quite extensive. For your OCAPs and for your clinical practice, you absolutely must know the top 3 differentials: ocular histoplasmosis, angioid streaks, and pathologic myopia. Let's drill down on the absolute board favorite.
Ocular histoplasmosis syndrome, or OHS. This is a massive high-yield flashcard moment right here. If you are ever presented with a clinical case featuring this specific triad, you must immediately think OHS. 1. Histospots, which are these punched-out chorioretinal lesions. 2. Peripapillary atrophy, or changes around the optic nerve. And 3. Disc-formed CNVM lesions in the macula. Also, remember, these patients will typically have a totally clear vitreous, unlike other uveitis syndromes. Spot the triad, nail the diagnosis.
All right, let's transition into section 6, our high-yield OCAP review. We're going to tie all this anatomy, pathology, and imaging into a coherent framework that you can take straight to the exam room and the testing center.
First up, let's connect the structural pathology directly to our management. For non-exudative ARMD, we can't cure it, but the ARIDS-2 clinical trial proved that specific micronutrient supplementation significantly reduces the likelihood of conversion to the wet form at-risk patients. For exudative ARMD, remember that abnormal OCT scan we looked at? Vascular endothelial growth factor, or VGEF, is the primary driver forcing those abnormal vessels to grow and leak. Therefore, interdicting or blocking that VGEF with anti-VGF intraocular injections is the absolute key to stopping CNVM leakage and saving the patient's vision.
Okay, rapid fire review time. Let's lock this in. Number 1, age is the strongest risk factor. Smoking is the strongest modifiable risk factor. Always counsel your patients. Number 2,
Drusen are literally just uncleared photoreceptor metabolic waste. Number 3. Basilinear drusens sit deeper inside Bruch's membrane. Don't fall for the laminar trap. Number 4. The normal outer retina relies entirely on diffusion because it is completely 100% avascular. And number 5. Histospots, peripapillary atrophy, and a CNVM equals the OHS triad.
I want to leave you with a final Socratic thought to ponder before you head into your next clinic. Knowing what we now know about how drusen physically alter the structural integrity of Bruch's membrane, what specific early structural changes on a standard OCT scan should alert you, the clinician, to predict an impending, devastating CNVM breakthrough before the patient ever even complains of a central scotoma? Apply your new anatomical intuition. Master the progression from normal tissue to clinical disaster. Keep investigating, and I'll see you in the next explainer.